You're listening to Treating Blood Cancers, the podcast series for professionals by Blood Cancer United. We'll be joined by cancer experts to discuss blood cancer diagnosis, treatment, survivorship, side effects management, and the importance of clinical trials. They will share their experience in treating patients and discuss strategies for optimal patient care. Let's get the conversation started.
Welcome to Treating Blood Cancers, the podcast series for professionals by Blood Cancer United. I'm Dr. Ken Miller. I'm a medical oncologist, a hematologist, and a Blood Cancer United volunteer. And I want to thank all of you so much for tuning into this episode as we highlight key insights into the 2025 American Society of Hematology annual meeting. Today, we're going to be joined by, and I'm very excited to welcome Dr. Laura Grunbaum, who is the Chief Scientific Officer and Senior Vice President of Research at Blood Cancer United. Laura, thanks for joining us.
Oh, it's my pleasure.
I have found that most ASH meetings are really exciting. There's a bunch of new information to present. What's your 60,000-foot view of 2025 ASH?
Yeah, Ken, I think this was definitely one of the more exciting conferences for a variety of reasons. I think it was a big conference for multiple myeloma, where we have just seen absolutely amazing progress, in particular with the advent of immunotherapies, both, of course, in terms of the CAR-T therapies, including the approved current therapies, as well as the next generation therapies, where we're really seeing some exciting new drug candidates moving through clinical trials with very, very good data. And on the somewhat related new modality, the bispecific engagers, which of course started out in late line therapy and are now continuously moving up towards really all the way up to newly diagnosed patients, including in a variety of different combinations. I think the things that we're starting to see a plateau in terms of looking at long-term survival of at least a third of late-line treated patients with approved therapy, cilta-cel in particular, which really makes us start to think about truly long-term remission, possibly even cure. And then we're really seeing that these types of data are being matched, if not surpassed, by the use of these therapies in earlier lines of therapy, starting in second-line therapy. And again, in really tough competition with data with the bispecifics, which I'm sure we'll going into more detail as well. The second highlight that I want to bring up is the continued excitement we saw earlier this year at ASCO and at EHA, of course, around the menin inhibitors, which are really providing a new type of targeted precision medicine therapy that has the potential to provide benefit to at least 30% of patients with AML based on their molecular characteristics, if not more, also including some patients with ALL. This is a field that Blood Cancer United has made tremendous contributions to, funding some of the earliest research that actually led to an understanding of the role of the menin-MLL complex in terms of the genesis of acute leukemia, and then also driving the development of the compounds that eventually led to one of the now approved menin inhibitors called ziftomenib, as well as continuing to be very actively involved with our two master clinical trials, the PETAL trial for pediatric AML patients, as well as the BEAT AML trial, where we're testing both approved menin inhibitors, revumenib in the BEAT AML trial and ziftomenib in the PETAL trial. So a field that has now really grown. It's hard to keep count. I'm going to say at least 7 or 8 programs that we see that are in the clinic or close to the clinic. And again, we're seeing a similar picture that these novel therapies really start out, of course, in late line therapy for patients that have exhausted all approved therapeutic options, but are now moving actually very, very fast, rapidly towards frontline, in particular in combination therapies, both with intensive chemotherapy as well as with azacitidine, venetoclax. And then a third theme that I'll highlight is really around fixed duration therapy versus continuous therapy. This is particularly interesting in the context of CLL and in the context of treatment with BTK inhibitors, where again, we've seen just a tremendous amount of innovation moving from the first generation, really ibrutinib being the first approved BTK inhibitor, to the second generation acalabrutinib and zanubrutinib. And then, of course, now the non-covalent inhibitors such as pirtobrutinibs and the BTK degraders. And again, really interesting studies that are really looking at the perspective to have a really good tolerability, continuous BTK therapy, but also to have equal benefit or potentially for certain patient populations, even superior benefit with a limited duration, fixed duration combination treatment that again includes an antibody-based treatment. So those are, I think, some of the themes. There's always a lot more going on at ASH, but if I were to just put forward sort of three big themes that I've seen, those would be them. Yeah.
I have to say, as a clinician in practice, there's so many choices now. I treat a lot of patients with blood cancers. For example, Bruton kinase inhibitors, there's a lot now. How is that going to reflect on the ability to do research, both with new drugs, combination therapies, trials like the fixed duration? What will be some of the challenges in studies, and how do you think, especially from a Blood Cancer United point of view, what might be some of the strategies to keep the research pipeline going with that challenge?
Ken, you're absolutely right that we've seen these tremendous steps forward, and you're rightly highlighting CLL. I highlighted earlier, I think, multiple myeloma. I have to say, sadly, we're not in a situation where we're seeing this type of progress across all blood cancers.
Yes.
We're, for example, not yet seeing it for the field of AML, where, again, we have introduced a number of targeted therapies. So far, we haven't really moved the needle that significantly yet when it comes to long-term survival. And we're learning sort of the hard way that early response rates don't necessarily translate to long-term survival. I think one of the challenges in AML has, of course, been to find targets that are broadly expressed across ideally blast as well as leukemic stem cells within each individual patients, but also across patient populations. And we're seeing that in spite of these amazing therapies, we still see patients who either have primary refractory disease or who relapse. And often the biggest challenge and what we're really focusing on are generally those patients who don't benefit. So those could be patients with high risk cytogenetics, double hit, triple hit lymphomas, or multiple myeloma, TP53 mutated disease across many blood cancers, for example. And then if I think about AML again, relapse after venetoclax-based therapies, we know that the biology of the diseases is changing. And so that means that we really have to go and understand how that happens and what the new targets and what the new approaches are and what potential combinations are. And one last disease that I want to highlight, where we have taken many shots on goal, and unfortunately we have failed almost every time, and that is high-risk MDS. Again, a disease that really has a very poor prognosis, right? And patients that truly do need better therapeutic options. We have unfortunately seen the Verona trial, the combination of azacitidine and venetoclax, that has been such a game changer based on the VIALE-A study for patients not fit for intensive chemotherapy with AML. And hopes have been high, of course, for this combination also for high-risk MDS. The trial did not meet its primary endpoint, even though there's been some evidence that there are subpopulations of patients that derive benefits. So something we're following up on. So at Blood Cancer United, we're really laser focused on those patients who do not benefit even from the latest therapies and those diseases that just haven't seen these advances. And again, I'll just list another one: T-cell malignancies, TALL, right? PTCL, some types of CTCL. So unfortunately, I have to tell you, there's a lot more to do. So that's what we're up to these days.
I actually just want to thank you, because sometimes it's easy to celebrate or try to celebrate the successes, but you're absolutely right. I mean, on a day-to-day basis. There is a tremendous need, and it's exciting to look at what Blood Cancer United is doing. And I say that also, I think a lot of people know, but my wife had AML. It's 25 years ago, and she's well, so we have a lot to celebrate. But it'd be nice to use the word cure like you did more often, right?
Absolutely. That's the goal we work towards. And, for me, Ken, it goes from chemotherapy to ideally a treatment option that is, chemotherapy free or chemotherapy light.
Right.
And then again, ideally a targeted therapy option or a combination of a targeted therapy with an immunotherapy that gives you a long-term remission. And I think then those diseases were there, and CML falls into that category to some degree, certainly
Right.
CLL. And I'm talking aside from transplant, and it generally has been the only truly curative option that we've seen for subsets of patients. But we're sort of going step by step. And I think for some diseases where we now have really, really large, high percentage of patients in durable long-term remission, that's where we can have these discussion around what are the criteria for stopping treatment. This is where all the new learning and the technology and the increased sensitivity for MRD assessment comes in. And how do we use minimal residual disease assessments to inform and identify in a sort of holistic approach who are the patients who we can potentially take off therapy? Because even pills that you have to take, there is no such thing as a drug without side effects, and it's obviously a financial burden and a significant general sort of quality of life burden, no matter what. So I think those are the steps we're trying to take. Yeah.
So let's dig in terms of, we talked about sort of three big topics: myeloma, AML, and menin inhibitors, CLL. What were the exciting abstracts and presentations on myeloma?
Yeah, so one abstract that actually generated a lot of excitement, this was a late breaker that I hadn't mentioned yet, was from a early phase 1 trial called In My Car of a in vivo CAR targeting BCMA in myeloma, KLN 1010. This is actually a lentiviral vector, so the same type of vector that is the basis of our currently approved autologous CAR T therapies. And it has been modified. It is nanobody targeted, sort of shielded from the immune system. It has an MHC class 1 knockout to mitigate the potential for immunogenicity. And the data presented at ASH was on 4 patients after 3 to 4 lines of prior therapy, high-risk cytogenetics, who all displayed, all of them MRD negative responses and remained in response through the current follow-up, which I believe was up to 5 months. And what was really remarkable also was that in this case, the tolerability seemed to be quite good, as much as we can judge it, of course, early with early data in a small number of patients. There was no neurotoxicity, no ICANS, or no delayed neurotoxicity, which is something that, especially with the approved agent cilta-cel, is something that gives us some headaches. Limited cytopenias, no treatment emergent infections. And the investigators were also able to demonstrate a very good expansion of the CAR T cells and demonstrate that they had a memory phenotype, which is, of course, really informative in terms of the potential for persistence of these cells, both in the blood and the bone marrow, and hopefully durability of response. And as you probably know as well, we've been trying really hard to turn the ex vivo CAR T therapy, which unfortunately has a lot of limitations and challenges for patients, manufacturing, etc., to turn that into an in vivo modality that could reduce a lot of these barriers. And this exciting data built on a report earlier this year. I think this came out at ASH and was also published in Lancet. Similarly, very small study. I think it was also 4 patients with, again, very good therapeutic responses, stringent CRs and PRs and good MRD negativity. I think that report earlier was an agent called ESOT01. Of course, all of these in highly pretreated relapsed refractory multiple myeloma patients had a bit more in terms of of tolerability, I think CRS, some neurotoxo, but again, showing really strong signal in terms of therapeutic responses. And that is just generating a tremendous amount of excitement in the field, because the potential to have the ability to replace, to some degree at least, the currently approved ex vivo produced therapies with an in
Yes,
vivo
yes.
approach is tremendous. Yeah.
Yeah, absolutely. Very, very exciting. Anything else in myeloma that you found was remarkable?
Yeah, I think one study, I'll just highlight one study as an example of what's going on in terms of bispecifics. And I think this is something that could truly be practice changing in the near term future. This was also a late breaker from the Majestic 3 trial. This is a combination of daratumumab and teclistamab. And this was actually a trial conducted in relapsed refractory patients after 1 to 3 lines of prior therapy, including a proteasome inhibitor and an IMiD, lenalidomide, I think in particular. And this was compared versus Daradex with either pomalidomide or bortezomib. This study met the primary endpoint, progression-free survival. The secondary endpoint, overall survival, was also significantly favored for the combination of daratumumab and teclistamab. So again, CD38 targeted antibody, BCMA targeted bispecific. I think they had about 35 months median follow-up, and the median PFS had not been reached for the dara-teclistamab arm versus the control at around 18 months. This treatment clearly has a somewhat increased infection risk. I think this is not surprising based what we know on these two individual agents. I think, if I remember this right, there was also some impact on COVID. These larger studies, we often still do see that clearly an impact of the COVID pandemic on some of the infections that have been seen. However, I think that the investigators reported that with the appropriate antimicrobial prophylaxis, IVIG, really good immunoglobulin monitoring, IVIG, they could really reduce the infection risk significantly. So this combination could truly potentially become standard of care as early as at first relapse for certain patient populations. So this is, I think, an example of a study that could really change how we're using these agents in earlier lines of therapy in the near term.
Let's move on to AML and the menin inhibitors. That was a big topic of interest last year. What was presented that was exciting this year?
With the menin inhibitors, as I said, the initial excitement was, of course, around the monotherapy data in the relapsed refractory setting. What was really remarkable at this meeting was the number of different combination trials, both in the relapsed refractory setting as well as in the newly diagnosed setting. And the data that we're seeing first and foremost are with the two approved agents, revumenib and ziftomenib, that I mentioned earlier. I'll just highlight a few of the data sets that I thought were really interesting. The phase 2 SAFE trial, for example, is a combination of revumenib with venetoclax and decitabine cedazuridine, which means that now we are having an oral combo there with the oral form of decitabine in newly diagnosed unfit patients with the typical characteristics: NPM1 mutated, KMT2A rearranged, or NUP98 rearranged, very high response rate, CR and MLFS around 94%, I think. There's also a number of studies looking at post-transplant maintenance, where, again, menin inhibitors also have the potential to really provide significant benefit. There was updated data from the phase 1 Augment 101 trial that led to the initial approval in the relapsed refractory setting. There are combo studies with IMiDs, such as mezigdomide, sort of next generation IMiD, gilteritinib, FLT3 inhibitor. The combination of a menin inhibitor with a FLT3 inhibitor has the potential to significantly expand the patient population that can benefit. There's some overlap between those patient populations, but it's not perfect. There's definitely an expansion that we're also starting to see, actually, even the first real world experience data on revumenib effectiveness and safety in a broader patient population. I think that's certainly something we'll be watching, especially because we know that revumenib has a black box warning for QTc prolongation and torsade de pointe. So this is something we'll be watching. Understanding and how to manage these side effects and minimize the potential is something that is a very active field of clinical investigation and just collecting experience. I'll highlight for ziftomenib, maybe the COMET-007 trial. That's an interesting trial, has two arms, both of them combinations with azacitidine venetoclax. One of them in newly diagnosed patients with NPM1 mutation or KMT2A rearrangements. They reported out on the NPM1 mutated patients 84% CRC after a median of 3.5 weeks. And then in the relapsed refractory setting, again with that triple combo, overall response rates for the NPM1 mutated patients around 65% and KMT2A rearranged around 33%. We also saw data for bleximenib, sort of a next generation menin inhibitor. Again, the two very typical scenarios, the combination with intensive chemotherapy in newly diagnosed patients eligible for chemo. This is a phase 1b study. Overall response rate over 95%, so really quite amazing. No QTc prolongation so far in this ongoing study. And then the relapsed refractory setting, also an ongoing phase 1b study with close to 70% responses, including for patients who had prior venetoclax or other menin exposure. Enzomenib is another sort of kid on the block in this new area of menin inhibitors in relapsed refractory patients, CR/CRh rates upwards of 45%, median OS of 11.4 months. Dose optimization is still ongoing there. So I think there's a lot out there, and we're going to have to watch this very closely. And I think the positive message is that very consistently, when these agents are combined in newly diagnosed patients, either with Veneza or intensive chemo, we're seeing very, very high response rates, well above 90%. And we're going to have to see the durability. At first glance, this is really exciting and promising data.
Laura, let me ask you, how are these findings and perhaps others being reflected in the BEAT AML trial?
So BEAT AML has been involved with the revumenib study that is looking at the combination with azacitidine and venetoclax in newly diagnosed patients not fit for chemotherapy. As we heard, a registration-directed trial is now being initiated based on the results from the study, which again, very consistent with the other studies I had mentioned, had reported very good responses, over 90%. And BEAT AML is aiming to remain closely involved in the menin field. So I hope to be able to give an update on that in the near future.
Since we're on AML and we're talking about BEAT AML, I hear that AI is, like in a lot of other places in our life, is finding a place related to the BEAT AML trial. Is that correct?
That is actually correct. And we've had the unique opportunity to work with a partner company in this space for almost 3 years now, with the goal to really integrate sort of agentic AI, so AI-driven automation, into the process of generating clinical trial regulatory documentation. And the benefits are actually manifold from that. It's a way of improving data accuracy and consistency, because the AI agents allow us to really cross-check documentation across multiple sources and support a very rapid turnaround quality assurance. And very importantly, it significantly reduces the time and the resources that are required for regulatory reporting. And I think, as we all appreciate, that documentation and the timely process is something that can be rate limiting when it comes to advancing clinical trials. So by having this ability to really rapidly generate full first drafts of complex regulatory documents, that frees up time, that frees up personnel to focus on higher value tasks.
Yes.
It really expedites data cleaning. And what we're focusing on right now with, in particular, our OPTI AML study that we hope to wrap up next year is going to be around TLF, CSRs, patient narratives, to really have these generated well before database lock. and get a head start on identifying any inconsistencies, refining this data. And so we've had a really, really positive experience. And I think this is something that we'll see much more broadly, hopefully integrated in the clinical development process and in clinical trials.
Let me ask you about CLL and fixed duration therapy. Again, were there any surprises there or things that were notable?
Yeah, so CLL in the plenary session, the CLL 17 study being presented, which is actually comparing a fixed duration treatment based on venetoclax, either in combination with ibrutinib or obinutuzumab, with the continuous therapy with the BTK inhibitor ibrutinib. And this is for newly diagnosed patients, of course. And this was really the first true comparison of this type of fixed duration doublet against continuous ibrutinib. The study was designed to test for non-inferiority for the doublet regimens. That was achieved. I think the 3-year progression-free survival was comparable for the regimens, around 80%. But deeper responses, including MRD negativity, were observed, in particular for the combination of venetoclax and obinutuzumab. But this study very convincingly demonstrates that this fixed duration treatment can potentially be a preferred treatment option for patients versus continuous ibrutinib. Now, of course, question is, when we're looking at the next generation BTK inhibitors rather than ibrutinib, what would that comparison look like? And we've seen at the same meeting I mentioned earlier, pirtobrutinib as the non-covalent inhibitor, which in a head-to-head comparison against ibrutinib, and this is a CLL 314 study, also met the primary endpoint of non-inferiority, with ORR and PFS actually trending in favor of pirtobrutinib. So we're seeing also, when you are looking at a continuous treatment option with pirtobrutinib, a really good option that has a very, very good tolerability, in addition to showing signs of potentially leading to improved response rates and also PFS. So those are really great options. There was a third study looking at pirtobrutinib versus bendamustine rituximab in frontline CLL. That study also met its primary endpoint. In this case, progression-free survival was significantly improved. A very large treatment effect, probably the largest one so far seen for any single-agent BTK against BR. So I think what we end up with are, again, some very, very good options, whether it's the time-limited therapy for patients who prefer that with a potentially better long-term outcome, off therapy, so you'll have hopefully a long time off therapy, but also with a continuous pirtobrutinib, a really valuable option that could be in particular interesting, maybe even in first-line treatment for elderly patients who could really have a long-term benefit. That means that they wouldn't really necessitate additional treatment.
So obviously there's so much talk and progress in terms of cellular therapies. And I'll ask you this, in a sense, the same question. What was exciting this year in particular about that?
Yeah, so Ken, we already spoke briefly about the in vivo CAR, and I alluded to the fact that also the approved therapies, in particular cilta-cel for multiple myeloma, if we saw some really nice long-term PFS benefit in standard risk relapsed refractory multiple myeloma from the CARTITUDE-4 study, which includes patients with 1 to 3 lines of prior therapy. So the 2.5 years PFS rate of 71% versus 43% control. And what was really interesting here was that the investigators were able to show that the earlier use of cilta-cel was associated with better immune fitness and stronger immune effects. And they were doing this by looking at a correlative analysis of peripheral blood and also bone marrow tumor microenvironment. We also continue to see exciting data on 2 other experimental CAR T therapies, one called anito-cel, which is using, instead of the scFv that the approved therapies are using for binding to the tumor antigen, is using something called a D-domain, so a different approach, a different structure. This is the ongoing Imagine 1 phase 2 pivotal study in relapsed refractory myeloma The investigators reported 97% overall response rate. These are now, I think, over 115 patients. And again, very encouraging, no delayed, no toxicities, Parkinsonism, no cranial nerve palsies, no Guillain-Barré syndrome, etc., no immune-mediated enterocolitis. This is an agent that could move forward very quickly, I think, towards an approval next year if the data continues to develop as it has. And then I also want to highlight another interesting new CAR T therapy called the FastCAR AZD0120. This is a dual CAR T therapy, and that's a theme that we see beyond multiple myeloma, also in large cell lymphoma. So dual targeting, in this case, BCMA and CD19. And data was shown, I think, from a couple of phase 1 IITs in newly diagnosed multiple myeloma patients. This is called FastCAR because it has a next day manufacturing process. And the data so far, smaller number of patients, I think 15 patients, had overall response rates of 100%, stringent CRs of 97%, very high MRD negativity. And again, very, very good tolerability, no ICANS. And what was also interesting here was that a lot of high-risk cytogenetics, were included in the study. So these sort of next-generation agents seem to also be able to achieve very, very good results in high-risk cytogenetics. And on the lymphoma sides, just to continue this theme, we've seen also some data from bispecific therapies. There's a, CD19, CD20, actually two different agents in phase 1 called Kite 753 and Kite 363. And 753 actually also uses a rapid 3-day manufacturing process that gives rise to CAR T cells that seem to be, more potent than in the traditional process. Very, very early data. There are just a few patients, but again, very, very encouraging data. And there are a number of other approaches in the lymphoma field as well, including using gamma delta T cells and not the traditional, generally used alpha beta T cells with dual targeting. So I think we're seeing improvements again in terms of response rates, improvements in terms of benefit for high risk, difficult to treat patients, and the tolerability is so good that these cell therapies are moving very, very quickly towards earlier lines of treatment, potentially even in select cases towards first line.
So I have to say, I totally agree with your first comment that it was a really good ASH meeting and a lot of exciting things for scientists, clinicians, and for patients and their families in particular. So again, this is Dr. Ken Miller. I want to say this has been a great, great session talking about the ASH meeting 2025, which was a very exciting meeting and a lot of progress. I want to thank all of you for listening, and I especially want to thank Dr. Laura Grunbaum, who is the Chief Scientific Officer of Blood Cancer United. Laura, thanks for being with us.
It's been a pleasure. Thank you for having me.
Again, I want to thank all of you for listening to this terrific episode. For a listing of all of our healthcare professional continuing education activities, podcasts, and healthcare professional resources, please visit bloodcancerunited.org/CE. For any questions or to refer a patient to Blood Cancer United, please contact our Information Resource Center by calling 800-955-4572. Information specialists provide personalized one-on-one support to help patients learn about their disease, treatment, financial, and support resources that are available in English and Spanish. Blood Cancer United also provides other resources for patients, survivors, and their families that can be found at bloodcancerunited.org/support. I encourage you to sign up also to receive notification of future podcast episodes by subscribing at treatingbloodcancers.org. And if you have suggestions for future episodes, please click the feedback button on this episode page. We look forward to you joining us on future episodes.
Thanks for listening to Treating Blood Cancers, the podcast series for professionals by Blood Cancer United. We can be found on iTunes and other podcatchers. You can subscribe at www.treatingbloodcancers.org and provide your suggestions for future topics. Visit our archive section on our website for other great podcasts. Be sure to rate and review us on iTunes. Keep up with Blood Cancer United by following us on social media and access our healthcare professional continuing education activities by visiting bloodcancerunited.org/CE. Let's keep the conversation going. Until next time.